Hi, thanks for joining us on our presentation of how mental health presents during adolescence and the impact of trauma. My name is Siobhan Threats. I am a district mental health specialist through Fayette County Public Schools. I have about 16 years of experience in the social work field, ranging from case management to individual therapy to various supervisor roles. My coworker, Katie Washington, will be introducing herself later on in the presentation. We will have 4 primary learning objectives today. The first being identifying unique traits from the adolescent stages of development and how they impact the treatment and presentation of mental health conditions, how you can help identify and support at-risk adolescents and determine next steps in identifying and addressing self-harm behaviors, have a greater understanding of suicidal ideation and suicidal behaviors in adolescents, and understanding the impact of trauma in adolescent well-being, specifically as it relates to mental health treatment. So first, we thought it would be a good idea to discuss the different phases of adolescence, or essentially, what are teenagers? Who are they? Where do they come from? We don't know, but we'll try to answer those questions for you today. So we will focus on a few phases of development. Adolescents go through a myriad of changes. While most are anticipated, some can be confusing and their impact can be overwhelming. So today we'll talk about the following 5 categories. The first being physical, emotional, cognitive, social, morals, and values. So for physical changes, for girls, they tend to develop earlier than boys, as early as year 7 or 8, and continue on to about age 15 to 19. So there's more hair, there's more weight, there's more height, there's boobs, and there's bleeding all the time. What's going on? For boys, they start a little bit later, maybe as early as 9.5, but continue on to a later age until around 21. So for them too, there's more hair, there's more weight, there's more height, their voice is changing, and there's stuff going on down there that maybe they were expecting and maybe they weren't. So what are the mental health impacts of these physical changes? So some teenagers or adolescents might perceive themselves as physically developing earlier or later than their same age peers, and that can lead to symptoms and presentations of anxiety, depression, low self-esteem or self-image, insecurity, grandiosity, bullying, eating disorders, and LGBT and gender identity. So with these physical changes, they might be more shy, more modest when those changes happen. They might want to cover up a bit more, be more reserved. On the other end of that spectrum, they might want to express their physicality a bit more, show off how they've been growing. So you have a different ways that mental health-wise those things can project. They might explore more questions about their sexuality. If their gender identity doesn't match, they may start to question that. They might fear those impending changes, those physical changes that they're experiencing. So all of those things are important to notice when we're thinking about how those physical changes can impact an adolescent's mental health. Next, we'll talk about cognitive changes. When adolescence hits, the brain starts to make new connections and starts pruning ones that they don't need anymore. What this leads to is no more black and white thinking. They're starting to reason, they're starting to rationalize, they're starting to question. They're starting to understand abstract ideas like love and justice. They start some metacognition, which is basically they're thinking about how they're thinking, right? So how did I come to that answer? Why did I come to that answer? Is the answer that I've come to making sense? So there's a lot of that going on too. They start to value short-term rewards over the risk. There's a lot of misconception that adolescents don't think about risk at all. They just kind of jump into their decisions, but that's not necessarily true. They are able to assess the risk, but sometimes when they're making short-term decisions, that reward part of their brain kind of takes over. And in their short-term decision, they might make a decision that might have negative long-term implications. They continue until their mid-20s for these cognitive changes. If you're thinking back to when you were growing up, that might make a little bit of sense that you might have it all the way together with how you're thinking about things until about your mid-20s. Looking back, I think that's true. So when we think about the mental health impact of these cognitive changes, now these kids think that they know everything because they are thinking through their decisions. They have a better idea that things aren't always what they seem, and they might question things. It might look like oppositional defiance. They're saying no all the time. They don't want to do things. They want to make their own decisions. And so that might come across as being oppositional. They might engage in substance use and substance abuse. They want to try new things. They want to see how it is. And sometimes they do things that might harm them, but they don't quite think it will until they try it themselves. There's more risk-taking. They're trying to push boundaries. They're trying to understand what they can and can't do. And so sometimes that looks a little risky. And usually when adolescence presents is when you start seeing the onset of mental health issues. So next we're going to talk about emotional and social development, and we're going to group those together because they're very interconnected. Through relating to others is how you gain insight into yourself. So the skills necessary for managing your emotions and successful relationships has been called emotional intelligence and includes self-awareness. So when we talk about emotional and social development, we talk about stress response, we talk about self-management, we talk about social awareness, and we talk about peer relationships. And what is maybe most important in this part is empathy, right? How can we put ourselves in someone else's shoes and kind of understand where they're coming from? And a lot of that has to do with how you are interacting emotionally with other people, how your peers interact with you, helps you develop that very important skill of empathy. So when we talk about the mental health impact of emotional and social growth, so there's a flood of hormones during adolescence, and the influence of your peer groups and the ability to manage that can be difficult to do. Teenagers often have really big emotional responses, and part of that is because that part of the brain is just developing. So when they are hurt in a peer relationship, those emotions can be really big, and so their social circles can be really, really affected negatively. And so this can look like interfering with planning or problem solving, right? So if you have a problem and you're getting really frustrated about it and your emotions are really high, it's hard for you to think of a plan for how to address that. You might see some elements of a depressive disorder. Again, emotions can get really big, and one of those emotions can be sadness. So you might see some of that. Anxiety disorder. How do I interact with my peers in the right way? How do I interact with my parents the right way? That can cause a lot of anxiety, a lot of anxious behavior. And there may be some self-harm. When it's difficult to manage your emotions, some adolescents find that self-harm is a way to alleviate that. And we'll talk more about self-harm and suicidal ideation later on in the programming. And then maybe there ends up being a lack of empathy. So if these children aren't given a lot of support, a lot of emotional encouragement, a lot of space to kind of express themselves emotionally, it might be difficult for them to then have a high level of empathy for others. And lastly, we'll talk about moral development. Now, moral development is contingent upon all those other phases of development. To create that, how was I treated when I started to look a little bit more grown up? How was I treated when I said I was sad or I said I was angry? How did people around me treat me in those situations? Now that I can think a bit better, what are my thoughts about social justice? What are my thoughts about how we should treat other people? So all of those phases kind of come together to help a person develop morally. So those are impacted by your friends, they're impacted by your family, they help you develop your moral code and to help you develop your worldview. So the mental health impact of that is navigated by the acceptance of your peer groups, and it's crucial at this time. You're trying to figure out what's right and what's wrong. Are there challenges to how you help and support your friends and family and the world at large? So some issues that might come across, again, might be some depression. You might be anxious. Am I making the right decisions? How are my behaviors impacting other people? I might have some suicidal ideation. If I'm losing hope, if I'm losing optimism, if I feel like nothing's going to change, I might feel like suicide might be an option. So now that we've talked about the different adolescent phases, we thought it would be a good idea to do a deeper dive into the different mental health diagnoses that adolescents might encounter. So now we'll do a deeper dive into depression, the definition, and presentation. In order to meet the clinical definition of major depression, a person must be experiencing 5 or more symptoms during the same 2-week period, and at least one of the symptoms should be either depressed mood or loss of interest or pleasure. And it must be most of the day, nearly every day. The other markers can be markedly diminished interest or pleasure in all or almost all behaviors most of the day, nearly every day. Significant weight loss when not dieting, or weight gain, or decrease or increase in appetite nearly every day. A slowing down of thought and a reduction of physical movement. Now, this must be observable by others and not merely subjective feelings of restlessness or being slowed down. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt nearly every day. Diminished ability to think or concentrate or indecisiveness nearly every day. Recurrent thoughts of death. Recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. So it's important to note that for adolescents, depressed mood might present more as irritability. They want you to leave them alone. Why are you bothering me? Get out of my room. And for boys, it might present more as anger. That's a more socially acceptable way of saying you're sad, is to hit something or to yell or to get into arguments or to throw things. Depression is not grief. That's separate. And it's not a response to a specific event like a breakup or being upset about school. It's a pervasive event, and it's not just a response to a specific event. So, for example, someone might break up with their boyfriend, and it's the end of the world, and because their emotions are really high, they're really, really sad about it. They're heartbroken. How could this happen? They were supposed to go to college together and get married and have kids, and now that's all finished. And because of that, they're depressed all the time. They're losing weight. They can't sleep, and it looks like depression because they're sad for about 2 weeks or even longer. So the difference between a response to an event and clinical depression is that typically clinical depression is not marked by an event. Typically, their depression presents kind of out of the blue and not a response to an event. You also want to look out for any physical reasons for depression and rule those out. So for example, someone might have some issues with their thyroid, and if that's off, then they might have some depressive symptoms. And you might also want to look at psychosomatic complaints. So maybe they're sad, but also like their stomach hurts or they're having headaches all the time. And maybe those headaches and stomach aches aren't explained. Those might be psychosomatic symptoms of their depression. So some risk factors of depression include a family history of depression, environmental stressors, hormones, and trauma. And now my coworker, Katie Washington, will continue the presentation with her discussion about anxiety.
Hello, my name is Katie Washington. I am co-workers with Siobhan at Fayette County Public Schools, where we are both district mental health specialists. I'm a licensed marriage and family therapist and have been working with kids and adolescents for over 10 years. I've worked in private settings, I've worked for the school system, and I've worked embedded in a school-based health clinic, which gave me, I feel like, a unique insight into the medical side instead of just the therapy world of dealing with mental health and adolescence. So I'm going to jump in and talk about anxiety, its definition, and its presentation in adolescence, because it can look a little bit different. So we're going to make this slide large so you can read along with me. Anxiety is defined by the DSM-5 as excessive worry, which is defined as apprehensive expectation, occurring more days than not for at least 6 months about a number of events or activities. It's the individual finds it difficult to control the worry, and the anxiety and worry are associated with 3 or more of the following symptoms: restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or your mind going blank, irritability, muscle tension, sleep disturbance. So that can either be difficulty falling asleep, staying asleep, or waking up unsatisfied by the quality of your sleep. So when we talk about anxiety in adolescence and we talk about 3 or more of one type of system set being required, let's dive into those a little bit. So the first is restlessness, being keyed up or on edge. Now, we talked about how this can happen in adolescent development anyways. They've got a ton of hormones coursing through their body, a ton of changes, and it might be a little bit harder to recognize this specific symptom. And remember, we want all of these symptoms to be observable, not just self-report by the adolescent. They might report restlessness, and that's really important for us to note, but it also needs to be observable by other people. Maybe they're not able to share a family meal that they were previously able to share. Maybe they're always on the go, where typically they were satisfied having a slower weekend. There's some subtle changes that we want to make sure we're asking the right questions to get at these symptoms. So you're going to want to ask what a normal presentation for this adolescent was, and then ask what they're seeing now to compare for yourself. Being easily fatigued. So this is not because they participated in some event, not because they're staying up late playing video games, but they're easily fatigued and we can't find an event or a reason. The next is difficulty concentrating or their mind going blank. So this is one that can easily be confused with ADHD, with the inattentive or the hyperactive subset, because they're not able to stay focused on one task. Again, we're going to want to look for this being a change from previous behavior, but it being pervasive for at least 6 months. And then irritability. This one's just really hard to capture in an adolescent because we see them pretty irritable a lot. But we're going to look at maybe your kid who is typically compliant is now snapping at you. Maybe a patient that you've been working with for years suddenly doesn't want to give you the time of day. And this is something that you're seeing over a course of several interactions. And then muscle tension. I mean, how many of us have been told, okay, relax your shoulders, and you didn't realize your muscles were tense until someone told you to do that? Well, this adolescent would be experiencing that type of muscle tension for an extended period of time. So now we're going to look specifically at sleep disturbance. So sleep disturbance looks a lot different in adolescence. So sleep disturbance is diagnosed depending on them having a typical sleep pattern, which we know is hard with all of the technology afforded to kids and especially adolescents. Your younger kids that I'm working with right now in an elementary school have tons of access to technology, and that only amplifies by the time they're in middle school and high school. So if you're worried about a teen possibly having anxiety and sleep disturbance is one of their main complaints, you're going to want to first talk about good sleep hygiene with that family and setting some rules around bedtime, wake-ups, and technology use in particular. So there are some unique parts about anxiety that I wanted to touch on that aren't necessarily listed in the DSM. There's not an adolescent page that you can turn to necessarily. And that's 3 specific things: panic attacks, school refusal, and social pressures. So panic attacks in an adolescent might be presented differently than they would in an adult. The teenagers not going to have the same words, especially young adolescents are not going to have the same vocabulary to explain what it feels like when they're having a panic attack. Adolescents also might choose to self-medicate using alcohol, marijuana, pills from other friends or from your own medicine cabinet. So adolescents don't typically go to their parents first with their concerns, they go to their peers. So if they're starting to experience something like a panic attack, their first stop might be to self-medicate. So our job as helping professionals or as parents is to help give them language to describe what's going on the inside so we can accurately diagnose a panic attack. The next is school refusal. So we all didn't want to go to school certain days. So school refusal is not every once in a while faking some type of illness. This is a habitual, repetitive school refusal where they're not wanting to go to school, and it might present as oppositional. We might see this as, oh, that kid just doesn't care about their academics, they just have lost all interest, they've got a bad friend group. Well, bad friend group might be part of it. As Siobhan told us, their peer group is king right now. Their peer group is what's most important. So if they're struggling with their peer group, they might choose the side of anxiety that's avoidant instead of the side of anxiety that's hyperactive. So that panic attack is that hyperactive. They are keyed up, their body, their hormones, everything's at a 10, and the school refusal is, I'm going to avoid all of it. I'm just not going to go. I've got a test, I know I'm going to fail it. We see that negative self-talk, and it can be hard to get an adolescent to re-engage in school if there's refusal. So you're going to see later on in the presentation, we talk about having really good connections with your local schools, and this is exactly why. The next is social pressures. The desire to belong and fit in during this developmental stage surpasses all else. So if there's any underlying tensions between group members and their peer group, on their sports team, in their dance troupe, this can really negatively impact the presentation of anxiety or take regular worry to a clinical level. Okay, so next we're going to get into trauma and mental health, and the reason I take a small pause is for us collectively experiencing this training to take a pause. We've all heard about trauma. It's kind of the buzzword these days, which in our world is fantastic. We are glad that the medical and the school community are jumping on board with understanding trauma and its impact on mental health. But as a mental health professional, we also want to look out for our well-being as helping professionals. So this type of information can be hard to hear and hard to digest. So as we go through this, we're going to have some built-in breaks that we really encourage you to get up out of your seat if you're seated while you're watching this presentation and stretch, participate in the calming activities that we're going to model for you, and really take care of yourself as you digest this information. It's easy to skip through it. It's easy to hear it like you've heard everything before, but today we're challenging you to hear this through the lens of your interaction with an adolescent when you only have a 20-minute office visit. We want to give you the background information to feel empowered, to help, and to serve. So we're going to head on into this next section by starting off by saying, what is trauma? So trauma in the medical world, we think about the ER, we think about that chaotic environment, we think about physical injuries. But in the mental health world, trauma is a different beast. Trauma is the response to negative external events or a series of events that surpasses a person's ordinary ability to cope. So that's the most important part. Your ordinary ability to cope is not effective when you're trying to process a trauma. It impacts the whole self. It impacts their physical, it impacts emotional, it impacts intellectual and spiritual. There is no part of us that is untouched when we experience a traumatic event. It's estimated that 1/2 to 2/3 of children have experienced trauma. So let's think about that. If 1/2 to 2/3 of children have experienced trauma, 1/2 to 2/3 of people in your social group, 1/2 to 2/3 of your peers, 1/2 to 2/3 of people that your children are interacting with have experienced something that is classified, research driven as a traumatic experience. And I'll dive into those definitions in just a moment. So not every child that discloses a traumatic event has long-lasting negative symptoms. It's not a blanket diagnosis, it's not a blanket situation. So that goes back to it has to surpass their ordinary ability to cope. So research does tell us that there's some negative health impacts though. So if you experience repeated traumatic events, also known in our community as complex trauma, then there's some pervasive negative health impacts that we see. And if untreated, they can continue on throughout a person's lifetime. So our next choice right now is to take that break. So I'm sure as I was talking about 2/3 of people experiencing trauma, you thought about someone you know, you thought about a patient, you thought about a family member. So we're going to take this moment right now. I want you to take a deep breath, and we are actually going to show you a guided meditation now that we really encourage you to join in.
Hey there, and thanks for gifting yourself these next few minutes. It's important to remember that you're a priority, and allowing yourself even just a few short minutes of intentional reflection can really have a positive impact on the rest of your day. So let's use these next few minutes to come back to center and set an intention for the rest of your day. Move into a comfortable position, whether you're seated at your desk at work or laying on the couch at home, and gently close your eyes and shift all of your attention onto your breathing, taking slower, deeper breaths than you've taken all day so far. Taking a deep breath in through your nose and slowly letting it out through your mouth. And continuing to breathe that way, feeling your lungs expand out as you inhale and contract back in as you exhale. Tune into your body, noticing how it feels, noticing if there's anything that it's trying to tell you. Notice any place of tension or tightness in your body. Give those areas permission to relax, sending love into those areas. Thank your body for taking such good care of you, and let it know that it's okay to rest and relax for these next few minutes. You may notice that your mind starts to wander off. That's okay. That's natural. Just notice it and bring your attention back to your body, using your breath as your anchor. Try to picture one thing that's happened today that's made you smile, or made you thankful or appreciative. And just let that feeling fill you up for a moment. Breathe that feeling in from the top of your head to the tips of your toes. And allow yourself to smile if that feels natural. Now focus on something that you can do today, whether it's for yourself or for someone else, that will allow you to continue feeling this way. It could be something as small as deciding to go to bed early tonight so that you have time to finally read that book that's been on your bedside table, or the joy of getting dinner with a close friend. What's one little thing you can plan for your day to bring that intentional joy to it? Now just focus on that for a few minutes. Sit in that feeling of joy and peace. let's take a few more deep breaths together. A deep breath in, feeling your lungs expand out as you inhale, and everything contract back in as you exhale. Again, an even deeper breath than the one before it, holding that breath for a beat, and exhaling everything out. Last time, your deepest breath yet, sending that breath through your entire body. And exhale it out. And in your own time, slowly bring your awareness back to where you are. And thank yourself for taking these few minutes to just be intentional and kind to yourself. And when you're ready, you can gently open your eyes and enjoy the rest of your day.
Some of us get scared at the term meditation. We think that we have to be able to do a certain mantra or be in some type of relaxed state for an extended period of time that we don't have. But I think all of us have the time for 3 breaths in between a patient, or 3 breaths out in the hall when we're taking a restroom break, or to take a moment and really sit up and take a full deep breath when we're charting. So I invite you to incorporate that into your practice, and we're going to continue on to learn a little bit more about trauma. So how does trauma disrupt childhood? So there's some basic assumptions that we all have about what childhood is. There's developmental tasks we're excited about, learning to ride a bike, having your first boyfriend, getting your first part-time job. We imagine a child has supports around them, whether that's parents or grandparents, a peer group that they play with. None of us picture our child as a loner. We all picture them surrounded by supports. There's certain experiences that we expect in childhood and adolescence, maybe joining a sports team, maybe joining the band or the show choir. There's different responsibilities. We expect them to start to get a part-time job. We expect them to be responsible maybe for cleaning up their room and doing their homework. And we expect their feelings to be a little bit all over the place, and that's just normal childhood. Well, the prolonged impact of traumatic stress disrupts each of these assumptions, unfortunately. There's developmental delays. Sometimes they're so arrested in their development that I will respond to a crisis call for a 10-year-old and he's absolutely displaying behaviors of a 2 or 3-year-old because he was not able to master his emotional expression at that age. Or I'll respond to a female who, when she gets scared, is unable to complete tasks that we know that she's mastered because we've seen her do them. So there's developmental delays that we see in children who have experienced trauma that sometimes go back to the time of the trauma, or sometimes just don't allow them to develop fully. And you'll understand when we talk about some of the neural impacts in a moment. There's a lack of the needed support to thrive. So children who have complex or repeated trauma are typically not surrounded by a family that has positive coping skills and that's able to support them. Humans are created to be in community. We need one another to thrive. We need the support of other humans when we're a child and when we're adults. So a lack of that needed support actually stops their ability to thrive like we would imagine a typical child would. People may not be viewed as helpful. If you feel like everyone around you who was supposed to keep you safe didn't, you're typically not going to reach out or respond to help the same way. That might be why as a nurse you see them respond differently. That's why teachers see children respond differently. If every time you counted on an adult to help you, they didn't live up to that expectation, you're going to stop expecting people to be helpful. And also their responsibilities at home might be greater. If we're looking at a child who's maybe exposed to repeated trauma and that trauma is parental substance abuse, they're having to step up and take on roles in their family that we don't view as a child's role. They might be taking care of siblings, not in a way where they're helping set out the dinner plates, but in a way where they're changing diapers, coming up with the meal, cooking the food at ages where those activities aren't necessarily safe and absolutely are not developmentally appropriate. So we also can see some possible maladaptive coping skills. Those around them might not have good coping skills, and we mirror our environment. So if they haven't been put in an environment where the coping skills are taking a moment when you're angry to calm yourself down, when their coping skill isn't reaching out for help, when their coping skill isn't going outside and taking a walk and blowing off steam in a productive, safe way, they might learn those coping skills, or like we talked about with anxiety, they might self-medicate the negative feelings they have. So this is also a slide I'm going to want us to take a look at for a few minutes. It's called the Adverse Childhood Experiences Study. And I hope that you have heard of it before, but if you have not, that's okay. We're going to go through it together. I'm in close communication with some residency program directors for family physicians, and their doctors come to them from very well established and respected medical schools knowing nothing about ACEs. So we can't help or treat what we don't understand, so let's go ahead and dive in real quick. If this is a review for you, it's always good to have these things on your mind when you're doing examinations or visits with children, adolescents, and adults. So the original ACEs study was done by the CDC and Kaiser Permanente. It's called the Adverse Childhood Experiences Study. The original research was conducted in 1995 to 1997. The sample size, and let me just tell you, the reason I'm going into these boring details is because I want you to see how generalizable this information is. It was 18,000 participants. 54% were female, so pretty evenly split male and female. 75% white, 75% attended college, and all of the families involved were considered middle class from Southern California. So we know that that is not the statistic for everyone that we interact with. And in fact, the education statistic is the most surprising, that 75% of the people in this study had attended college. 2/3 of those individuals have at least one adverse childhood experience, and 1/5 had 2 or more. So when we talk about an ACE, that's abuse, which is physical, emotional, or sexual, neglect, physical or emotional, and household dysfunction, which is defined as mental illness, the mother being treated violently, divorce, incarcerated relative, or substance abuse. So as we see an adverse childhood experience, that's the bottom of our pyramid, that can lead to disrupted neurodevelopment, which can lead to social, emotional, and cognitive impairment. Remember, we're in adolescence. All of those things are exploding with development right now. They can have the adoption of risk behaviors that put their health at risk, which can lead to disease, disability, and social problems, and ultimately in early death. Understanding trauma really is that serious. So the next slide we're going to take a look at, that we're going to focus on again for a moment together, is the second major finding of the study. And that's that negative coping skills are related to higher ACEs. So as your number of adverse experiences increases, your risk for these negative coping skills also increases. So these are not listed in order of severity, they're just merely a list. So we have smoking, severe obesity, suicide attempts, alcoholism, drug abuse, 50+ sexual partners, repetition of the original trauma, self-injury, and eating disorders. That's a pretty heavy list to think about. So as the number of adverse experiences increases for a person, the possible negative health outcomes also increase. So as a healthcare worker, you have the opportunity to look at somebody who is smoking, to look at somebody who's reporting multiple sexual partners, to look at somebody who's reporting alcohol or drug use that you feel has crossed the line from recreation into an actual substance disorder, and not just address it medically, but realize that it's possible, considering 2/3 of people have experienced trauma, that there's an underlying traumatic event that has left unresolved difficulties that's causing them to turn to that coping skill. And really, our lens with how we view the people that we treat and care for matters tremendously. The next is we're going to see this lovely picture of this little girl who, without all those blue boxes, just looks like a normal, typical kid. Well, here we're going to talk about how the physical impact of trauma has changed her at a cellular level. I'm going to go through and read each of these, and I'm going to pause to also give you some hope Because again, I'm all about self-care. I'm all about us taking care of ourselves as helping professionals, and I think we need a little bit of hope imbued right about now. So the first few things I'm going to talk about are neuro and brain development, and then I'll hit you with some hope, and then we'll talk about some other cellular changes, and I'll hit you with some positive outcomes again. So the first is their brain architecture changes when they experience trauma. They have shown with fMRIs shrinkage in the prefrontal cortex, the corpus callosum is not well developed, and the hippocampus has also become smaller. They have an enlarged and more reactive amygdala, and that's our danger center of our brain, and we're going to spend some time on the amygdala, and my coworker Siobhan will also spend some time on the amygdala because it's a key player here in trauma. The neural pathways, they need to be rewired because they've been wired to survive. They've been wired to respond to a traumatic event quickly and immediately with survival as the forefront, not concrete, abstract thinking, planning, any of those things. Their brains have been wired to respond and survive. Their brain waves, there's a predomination of the wrong brain waves in the wrong parts of the brain. So that's leading to anxiety. They're unable to concentrate, and they've even seen something as severe as seizures in the absence of a physical injury. The neurotransmitters have also been either over or underused, so that makes them vulnerable to addiction. Dopamine transmitters and receptors have not developed or have been damaged. That reduces motivation and focus and creates fatigue. Serotonin is also, research has shown to be lower in the brains of those who've experienced trauma, which leads to depression in most cases. The hormones, so we're all the rage at this age, but now we're talking about hormones that aren't promoting positive adult development. We're talking about prolonged high cortisol relating to greater reactivity to stress. So long-term damage to cells and structures of the body that were not designed to be in a state of alert all the time. So I promised I would imbue some hope. So let's talk about how we can correct, resolve, and retrain. Really awesome news. Appropriate mental health and behavioral health treatment has been shown to rewire the brain. It actually will help the brain cells create new pathways, strengthen pathways associated with self-control and self-regulation. So things like meditation, neurofeedback, mindful action, and positive self-talk actually rewire the brain. I just think that's so cool. We also can use neurofeedback, actually walking outdoors and experiencing nature and experiencing low anxiety. Positive input helps. Positive touch and appropriate affectionate relationships, as well as occupational therapy that includes sensory information, have all shown to help reshape the architecture of someone's brain who's experienced trauma, and it's never too late. There are hard set times when our brain prunes, and we know that, but the really cool research is that our brains never stop learning and they never stop changing, and because of that, therapy will always be able to come alongside a patient and help them create positive impacts. So let's talk about the cellular change. They actually have shown that children who experience complex trauma, they have shortened telomeres, which prematurely ages and reduces the reproduction of cells and can cause cancer. Epigenetics turns genes on and off in adaptation to dangerous environments. So there can be generational impacts because the trauma is actually seen in our DNA, is changing how our DNA is responding to environments, and there can be generational impacts from one of us experiencing complex trauma without appropriate supports and without the ability to find some type of positive mental health and behavioral health treatment. So that tells us that we need to create safer and more supportive environments where people experiencing trauma can experience moments of absolute safety. The nervous system's supercharged, and the sympathetic nervous system. So the parasympathetic nervous system is not engaged to bring back balance because your body and your brain feel as though they are in danger. There's no self-correction because they truly are in danger in some situations. So this is we're going to talk more about this aspect when we see kids in our clinic tearing up the waiting room, or when we see kids in a classroom who are completely dysregulated and acting inappropriately with peers or teachers in a way that seems completely disproportional to what is happening. we can root it back to an experience of trauma and a negative coping skill that they're using. So next, we have a video about stress hijacking the brain of a kid as they just try to sit in school and learn from their teacher.
The reality is that we all need a certain amount of stress, a certain amount of anxiety to perform well. If we don't care about that exam that we're going to have tomorrow, we'll probably fail. If we're going to cross the street and a truck is coming at us, we have release of adrenaline. We have release of a hormone that we call cortisol. We want to jump out of there, and adrenaline and cortisol are going to help us do that. So there's that good amount of stress. But if all day long you're feeling like a truck is coming at you, day after day after day, that's going to take a toll on the body. And the amygdala obviously here has greater activation.
Yes.
In the PTSD. We were able to image children that had experienced trauma and compare those brain images with children that didn't have an experience of trauma and didn't have symptoms.
Right, an exaggerated fear response.
An exaggerated fear response with decreased activation in areas that we need to control that emotion, in the frontal areas.
Exposure to early adversity and trauma literally affects the structure and function of children's developing brains. So the kid next to them hits them, or the teacher reprimands them in a way that they're uncomfortable with, right? Literally what they're feeling, that activation is like there was a truck coming at them. You can give something that will mask symptoms, right? For example, if someone has a cough, right, you can give them a really strong cough serum that will suppress their cough. But if it's because they have tuberculosis or lung cancer, then what you're doing is merely masking the symptoms while the disease process continues to fester. We know what's happening in children's brains and bodies with the experience of toxic stress. So the question now is, what do we do about it?
Thank you for sticking through and watching that video. We find it to be very impactful to actually have the visual representation of what's happening to these kids who are in our office. So while we may see somebody who looks calm on the outside, there can be trucks driving through their amygdala on the inside. And to talk more about what it looks like when stress hijacks the brain and to dig a little bit deeper into that, we're going to bring Siobhan back to discuss the architecture of the brain and how stress and complex trauma negatively impacts the brain.
Thanks, Katie. When I do trauma trainings and I talk about trauma with the kids I see, I think it's really important that they understand how their brain was affected by trauma. So I am going to do a quick demonstration and breakdown of how the brain works and what happens when trauma occurs. So we'll talk about the brain stem, the amygdala, and the frontal lobe. So one of the things I really like to do is do a demonstration with my hand about how the brain works and how it's developed. So you take your hand and you make a fist with your thumb covered by your fingers. And you explain that this is essentially the brain stem. This is what keeps us alive. This is what keeps us breathing and blinking. Those automatic things that we don't have to think about, right? So you don't have to think about your breathing. You don't have to think about your blinking. It just happens automatically. So this is the brain stem. Next is the amygdala. And this is where our fight, flight, freeze, food, and mating decisions occur. So when we come across something, our amygdala thinks about, do I need to fight it? Do I need to run away? Do I need to freeze? Do I need to eat it? or do I need to maybe mate with it? So those basic responses are in the amygdala. And as we evolved, our brain developed the frontal lobe. And so that frontal lobe has us thinking about, do I really need to eat it? Do I really need to fight it? What is the meaning of life? Why are we here? All of those decisions encompass that and kind of temper what the amygdala is thinking about doing, right? So brainstem, amygdala, what do we do about it? The frontal lobe has us questioning our decisions and what we need to do. So one of the things I do in my trainings as well is I take people on a kind of guided meditation through the woods. So you kind of pretend like you're walking through the woods. It's a beautiful day. The sun is shining. And all of a sudden, there's a bear. Not just any bear, a really angry bear appears right in front of you, right? So once the bear appears, what do? And so I have everyone think about different options. Some people say that they'll shoot the bear. Some people say that they'll run away. Some people will fight the bear. Some people will play dead, right? So all of those fight, flight, or freeze events, and we just kind of imagine that one of those worked, right? So you fought the bear, and you actually were able to fight the bear, and you were able to get away. You climbed up the tree. The bear didn't chase you, so you were able to get away. You played dead. That worked. So some weeks or months go by. You and your friends decide to go to the zoo. And at the zoo, there's some bears. And so after that traumatic event, you see this bear at the zoo, and automatically your amygdala gets triggered and it flips the switch of your frontal lobe, right? So when you see this bear, you're thinking back to when you last saw a bear and you almost got attacked and what you did. So did you run away? Did you fight? Did you freeze? And you might be thinking of doing those things at the zoo, right? So when you're at the zoo, it's going to be weird for your friends to see you maybe run away from the bear or try to shoot the bear at the zoo. To them, it doesn't make any sense. But for you, it makes perfect sense because the last time you saw a bear, the bear tried to kill you. And so you had to do what you had to do to get away from the bear. And so that's what we talk about when we say flipping the switch. So once danger is registered, the amygdala overrides all of that. And so that's what we mean by flipping the switch. The amygdala takes over because the amygdala wants you to be safe. So you're thinking again, what do I need to do right now to keep me safe? What worked before? And you don't have time to think about the effects of your actions on other people, right? You're only thinking about how can I be safe in this moment? And if you don't feel like you're safe at the zoo, you might make what other people view as irrational decisions in the moment, but in the moment for you, you're feeling better. Another analogy that I like to use is referencing The Walking Dead with the zombies. Now, maybe that's not real life, but it's also not the end of the year by what's going on. Maybe we will have some zombies later on. But what I talk to people about is in The Walking Dead, I want people who have that switch flipped. I want people that are always thinking about, do I need to fight it? Do I need to run away? What do I need to do to keep safe? I don't need to worry about the zombie's feelings, right? Is this a good zombie or a bad zombie? We don't have time for that. We need to make sure that we're okay. And so in situations where there is danger, flipping that switch can be okay. And so what we try to teach our kids who have gone through traumatic events is that if they're in a safe space, that they can use different skills that they learned that are different from when they were traumatized before. And so that's kind of the essence of a lot of trauma-informed work, is rewiring those pathways, as Katie said, and as we mentioned before in that development, that those neural pathways were created in traumatic events, right? And so because they were created in traumatic events, they respond in a traumatic manner. And our role is to make new pathways for them, for their development, and for their coping skills. So with all of the different symptoms and behaviors that come along with trauma, there are some commonly misdiagnosed disorders. Those can be attention deficit disorder, right? So kids that seem to be having a lack of focus, or they're paying attention all the time, or they're not paying attention to their work. It might look like ADHD, but in reality, they're just hyper aware of their environment and they're looking out for danger. Bipolar disorder, so kids might have really extreme responses that seem to not quite fit the situation. That might be a trauma response, but that might be misdiagnosed as bipolar disorder. Disruptive mood dysregulation disorder, again, kids might look like they are having extreme reactions to minor events, but at the same time, they might be having trigger responses that might respond to trauma reminders. Oppositional defiant disorder. Kids might be trying to tell you, this isn't working for me. I can't do it. Maybe they can't explain why they can't do it. And so people are assuming that they're being defiant, when in reality, they're trying to keep themselves safe and they're trying to tell you that, but it's coming across as oppositional. Depression, that's more obvious, right? When bad things happen to us, we get sad. And so maybe we're sad for a very long time and we're depressed for a very long time. Depression and PTSD aren't necessarily mutually exclusive, but you don't want to dismiss someone's depression and maybe not do a deeper dive and to ask what happened to them. Again, anxiety. They might present as nervous, as irritable, that it's difficult for them to make plans and do things they would normally do. Again, coming across as anxious, but those might be trauma responses. So when you're thinking about all the different symptoms and behaviors that you're seeing, you really want to think through which diagnosis most closely represents what is occurring in their brains and in their bodies. And Katie will take us into a deeper dive on the specific symptomology of PTSD.
Thank you, Siobhan, and I love how she described the hand brain, and it's something that is quick and easy, and you can talk with your parents and the children and the adolescents that are in your office about that, and it will really help connect some of that for them. So while we talked about the commonly misdiagnosed disorders, so these people might come into your office already having that whole list of commonly misdiagnosed disorders, but what we want to look for is PTSD. So we're going to look at the criteria for diagnosing PTSD and also realize that you might see people who are on their way to developing PTSD, and those diagnoses are typically adjustment disorder or acute stress disorder, and it doesn't deal with the symptoms as much as the period of time. So again, back to what I previously said, trauma, for it to be diagnosable as a mental health condition we're going to treat, such as PTSD, it has to be beyond our ability to cope. So when we get to PTSD, it is absolutely beyond our body's typical ability to cope with what's happening in our brain and in our bodies. So the first criteria makes sense. It's an actual exposure. So there has to be exposure to actual or threatened death, serious injury, sexual violence in one or more of the following ways. So the person has to directly experience the event. They have to witness in person the event as it occurred to others. They have to learn that the traumatic event occurred to a close family member or close friend, and that one can be tricky because society will tell them that they shouldn't be traumatized. But we all know that hearing about your loved one being brutally attacked or continually victimized is very difficult. Or experiencing repeated exposure to adverse details of traumatic events. And this is why I preach coping skills, because in our line of work, we are constantly bombarded with really difficult details because our society is conditioned to trust us with that information, which we love. That's why we're helping professionals, but it also can start to take a toll on our own mental health if we don't keep it in check and encourage those around us to keep that in check. So then we have to see the presence of one or more intrusive symptoms associated with the traumatic event. An intrusive symptom is something like you're sitting in class trying to do math and the math problem talks about a grocery store, and boom, you're sent right back to the grocery store in your neighborhood where you saw someone mugged. That's an intrusive symptom. It comes up, you didn't invite it, you didn't ask it, it is unwelcomed, but here it is. Nightmares can also be considered intrusive symptoms, and things like being hyper-aroused to a trigger can be intrusive symptoms. The next criteria is persistent avoidance of stimuli associated with the traumatic events beginning after the traumatic event occurred. So if someone was always afraid of Chuck E. Cheese, that doesn't count. If they experience a traumatic event where somebody was masked or veiled or they couldn't see their whole person and then they're afraid of Chuck E. Cheese, that's an avoidance symptom. I hate to throw Chuck E. Cheese under the bus, but he terrorized me as a child. I just could not get that image out of my head. So our next thing is that there have to be negative alterations in cognitions and mood associated with the traumatic events. Again, beginning after the traumatic event occurred and is evidenced by some of the following events that we're going to get to on our next slide. But we need to focus here on if there were negative alterations in cognition and mood prior to the trauma, they might be accurately diagnosed with depression or anxiety. But if these negative alterations in cognition and mood occurred after the trauma, we might be looking at PTSD, and the treatment is different. It's hardest to tell when we know that somebody started experiencing complex trauma at a young age. It's hard to tease out whether they would have developed some of these underlying mental health conditions due to a genetic predisposition or whether they have developed them as related to trauma. Our rule of thumb is to treat the trauma and then to treat any co-occurring disorders, because if we treat the trauma, they're going to get coping skills. They're going to get some positive alterations in their mood, some positive changes in cognition, and we would rather treat the trauma first and address other symptoms as they come, with the exception of when their life is in danger, which we'll get to when we talk about suicide. So, talking about PTSD, realizing that this has to be a clinically significant level of impairment in their daily functioning, the duration of the disturbance has to be more than a month, so it's shorter than some of the other conditions. Anxiety and depression want a 6-month time snapshot. PTSD says if you are still having extreme reactions and it's been a month, that you can qualify for this diagnosis, which is a change in the DSM-5 that was very welcome by those of us in the mental health field. We had a lot of people underdiagnosed with PTSD due to the time frame needing to be so long. So I practice what I preach, and I'm going to teach you another quick coping skill. This is something you can do in your office. This is something you can do with your colleagues, or you can do with your patients. So this coping skill is called the SOS. It's adapted from Target, which is an evidence-based practice for trauma treatment. It's Trauma Affect Regulation Guide for Education and Training. Glad they shortened that to Target. I've used this very effectively with adolescent males, and I've just had some really great results. So I want to share this with you. It's got some unique pieces. It's more than just a deep breath. So the first step is we slow down. The second step is we orient ourselves, which might be new to you, so we'll talk about that. And the third step is a self-check, and that's my favorite. So the first step, we slow down and we do what is a typical deep breath. We take that moment to ground our feet, to square our shoulders, we breathe in, we sweep our mind clear, and we let our body and our spirit become calm. And I love the language that they use in Target, that we're getting our body and our spirit to have a moment of calm. The next is orienting yourself. So you're focusing on just one thought that helps you remember who you are, what you believe, and what is most important to you. Now that can be a big thing to digest, and especially for our younger children. So we help them. Some orienting thoughts are, I want to make myself proud. I'm here for a reason. I am here to help people. I can work hard. I know that I am more than my diagnosis. So it's just a short little phrase. It might be something that you actually write down and put next to your computer or workstation that orients you. The one that I go back to the most is I'm here for a reason. So whether that's I'm in this session with this child for a reason, I'm training these people for this reason, that there is a higher purpose to what I'm doing, that always is very orienting for me and helps me silence all of the negative voices in my head that might be telling me otherwise. And the last part, which I said was my favorite, is a self-check. Now you're checking in on two things. One, you're checking on your level of stress from 1 to 10. But 2, you're checking on your personal control. And that to me is really important, especially for kids, because their stress might be at a 9, but their sense of personal control might also be at a 9. Your stress level might be at a 2, but if your sense of personal control is at a 0, you might still be feeling negative feelings related to that event. So how much control we have over a situation is just as important as how much stress we're experiencing from that situation. So now that we understand the activity, we're going to take a moment and do it together. So that first step, I close my eyes. It's more grounding for me to do so. So we're going to slow down. We're going to sweep our mind clear and let our body and our spirit become calm. Now I want you to orient yourself. Focus on what you believe in and what matters most in this moment. I want you to take one more grounding breath. Open your eyes and rate your level of stress and your level of personal control. So in this moment, you can create a plan if you feel like your personal control is low. You can feel assured if you feel like your level of personal control is high, because sometimes that level of stress from 1 to 10, we can't control it. So as we move forward, and I hope that experience was able to be calming for you, we're going to talk about what types of mental health treatment are effective with these types of diagnoses. So this is the important part, right? We want people to get help. We don't want to just know this information. We want to be able to use this information. So people might come to you already with a diagnosis of adjustment disorder, acute stress disorder, or post-traumatic stress disorder. And again, some of that might be practitioners who are still diagnosing on old time frames. Some of that might be that their presentation at this time or their ability or willingness to disclose to the last medical professional they saw didn't help them reach the criteria for PTSD, but we know there's some trauma present. And we know that it's negatively impacting them. Because you and I both could be in a negative situation. You and I could both be in a car accident, for example, and the next day I'm fine. I get in my car, I drive, I don't have any lasting negative effects. You could experience the exact same interaction at the exact same intersection, but depending on your ability to cope at that moment, you might struggle to get in your car to drive to work the next day, or might have heart palpitations at that intersection. So we really need to know the symptomology, not just the traumatic event. Now, the mental health treatment, the Cadillac of mental health treatment, as it were, is cognitive behavioral therapy. And this is because it works on changing those cognitions, those ways of thinking, those behavior choices. And this is by no means an exhaustive list, but these are some of the most common and very evidence-based, very good outcome therapies that we use a lot in Central Kentucky, and that's TFCBT, so trauma-focused cognitive behavioral therapy, which requires specialized training in really understanding trauma and additional certification practices to be able to use it, which is great. So you know you're getting a high level of care if you're with a TFCBT certified therapist. The next is Target, where our SOS came from, and it is a group-based therapy. It can be done with individuals, but it's meant to be in a group, and it's specific for adolescents, which is great. There's activities, it's an interactive group therapy setting, and we're able to do it in the schools as well as in outpatient settings. And then there's TST, which is trauma systems therapy, and I love this one because it takes everything around that person into account and works to change every system that child is involved in, which is phenomenal because kids spend just as much time in other settings as they do in their home setting, and TST really tries to address all of those settings. So treatment mainly focuses on changing negative cognitions, understanding our emotions, and education, knowing that, hey, I just flipped my lid. I'm not a bad kid. I'm not mean. I'm not hateful. I'm not a disappointment. My brain is doing exactly what it was designed to do, which is keep me alive. So knowing that information about trauma, knowing that if they were to look around their classroom, half the other kids in that room have experienced a traumatic event, those things help kids feel less alone, more willing to seek treatment, and more willing to engage in the process of change. If they feel like they're a bad kid, they don't feel any hope to change. So by using psychoeducation, educating families and children about trauma, we're changing how they view themselves, and that's such a powerful tool that we have in our toolkit. So you might be thinking, what do I do with this information in a 20-minute office visit? And let's be real, it's probably less than 20 minutes. Like I said, I used to be embedded in a health clinic, and I know you guys have to move in and out of those situations pretty quickly. So the first step, I think, always create strong partnerships with community mental health agencies to provide families with referrals. Now, I know across the state, your access to mental health care is going to vary widely. Some people are going to have a list of 10 providers they can call who are willing to work with those families and who are very responsive to referrals. And some are going to have one that might be 30, 45, an hour, I don't know how long, away from your specific clinic. So the onus is on us to create strong partnerships within our community so that we can provide families with referrals, because that might be all we have time to do is put a pamphlet in their hand or a phone number or a business card and say, you know what, I really think it would be a good idea to call and talk with somebody more about what you shared with me today. The next is to bring this greater understanding that health conditions can have underlying mental health and trauma roots. Depending on the culture of your office, you might be fighting an uphill battle, or you might see that everyone around you is trauma informed and is on the same bus and you're headed in the right direction. So you can bring back this information about trauma and additional research you do on your own and really make your clinic, your space, your office, your administration trauma informed for your employees, your fellow coworkers, and ultimately your patients. So educate them on the impact of trauma. Say, they're losing weight. I wonder if something happened. Just posing that question, I wonder if something happened, can really change the way we provide healthcare. And then next is get more continuing education. This short presentation, which might not feel short at this time, and that's okay, is not exhaustive. It is not all of the information that is out there. It's what we felt like was most important to share in the amount of time we had. And there are tons of great resources, and we will share them on our resource page, and a quick Google search will help you a lot too, because luckily places like the CDC are on this trauma train with us, so you'll be able to very easily weed out the good research from the maybe not so great research by looking for organizations that have funding and that have research-based interventions listed for your particular position. Also, partner with your local school. We are super fortunate that we are district mental health specialists in Fayette County. And while your school might not have district mental health specialists, they certainly have guidance counselors and most likely have social workers. So having appropriate releases, but partnering with your local school will give you access to resources that you might not have within your building or your office. But your local school might have a deeper relationship with the family and might have different avenues that they can help people even if you're not able to provide the type of care you wish you could because of the limitations of your clinical setting. So next, we're going to move into high-risk behaviors. We want you to come away from this with information and feel equipped. We know that when adolescents display high-risk behaviors, it makes all of us anxious, and that's okay. Even Siobhan and I, who have been doing this for a long time, we still will run across kids who, when they respond to some of these questions, that yes, I feel that way, or yes, I've been thinking about this, or yes, I've tried this, it still impacts us. So we want you to know that you're not alone if dealing with high-risk behaviors makes you feel a little bit uncomfortable, and this is a great time to have excellent documentation in your notes so that you can keep yourself safe and your patient safe. So I'm going to turn it over to Siobhan to talk about self-harm, and then we're going to show you a wonderful free tool to also document suicidal ideation.
Thanks, Katie. One of the things that we want to make clear during this section is that there are clear distinctions between self-harm and suicide. They can be mutually exclusive, and that self-harm doesn't necessarily lead to suicide or suicidal ideation. So what is self-harm? In the most general sense, self-harm is any intentional injury to yourself. Clinically speaking, non-suicidal self-injury is the intentional infliction of physical pain or damage to self without suicidal intent. 7 to 14% of teenagers have engaged in self-harm at some point. So I wanted to go over some typical presentations of self-harm or forms that might be familiar to you, and some that are maybe atypical or aren't as familiar, and there's just some limited research on if those expressions of self-harm are warranted. So you may be familiar with cutting. That can use any sharp instrument to cut yourself, burning, or scratching. So those are three kind of main shows of self-harm that you might see in your practice. Atypical might be excessive drinking, right? So you might drink to the point of blacking out or throwing up. Drug use might be seen as a way of self-harming. Extreme sports, there's some limited research that shows that people that engage in extreme sports, there's a risk in that. There's a risk of hurting yourself in those sports, but it's also more socially acceptable to engage in that. Same for tattooing. There's some limited research that shows that if people tattoo often, that might be a more socially acceptable way to engage in self-harm, and also unsafe sex practices. So you might be having unprotected sex, knowing that it can lead you to risk of STDs, but you might engage in that anyway. So the million-dollar question is, why do people self-harm, right? So kind of intuitively, for a lot of us, that doesn't make sense. Why would you physically hurt yourself? It hurts. You know what I mean? Why would you do something that causes you pain and say that it's helpful? So we're going to break down some of those reasons, and hopefully that'll help explain the need for self-harming for some people. One is an emotional release. So some people that self-harm, their emotions can get so big, right? So as we mentioned before, in the developmental stages, those emotions can get really overwhelming. So there's that. There could be trauma responses that they're responding to. And so for them, the controlled physical pain that they can give themselves is able to distract them from the emotional pain that they're going through. Some people might engage in self-harm for attention seeking. Now, this is pretty rare. Most people don't hurt themselves in order to get attention from people. So we don't want to make it seem like most people that self-harm, they're just doing it for attention and they want their mom to, get them off punishment, those kind of things. Typically, self-harm for attention seeking is rare because it's not as helpful as other means to get attention. And lastly, It might seem weird, but it helps people calm down. There's some new research that indicates that people who self-harm have low cortisol levels and higher pain tolerances. So when they engage in self-harm, what happens is it helps them calm down. So that's why sometimes it doesn't make sense for us if we don't have a high tolerance for pain and our cortisol levels aren't low, that when we hurt ourselves, it just hurts. Nothing is helpful. That didn't do a thing for me. But for these kids and adults, it makes sense for them to do. And for those reasons, when kids come into therapy, a lot of therapists don't necessarily say, don't hurt yourself anymore. Let's stop that cold turkey, because we have to find something that'll replace those behaviors. So in the meantime, we might say, let's get a rubber band on your wrist and you can pull the rubber band. You might be able to get some ice cubes and rub that on your hand. You might even be able to use an eraser. Those are ways that can kind of mimic that pain, but don't leave scars or marks. And so we might give them those alternatives while we then try to help them develop their coping skills in different ways to manage their emotional pain that doesn't cause any kind of physical damage to them. So moving on, we'll talk about the different risk factors for self-harm. So that can be child maltreatment, as we mentioned before, history of physical abuse, sexual abuse, neglect, complex trauma can be a risk factor, parental drug or alcohol abuse, exposure to domestic violence, parental mental health concerns. And I want to take a minute to talk about that, because as kids get older, they might be better able to comprehend the mental health concerns of their parents, right? So now they notice that maybe mom is actually depressed, maybe mom's anxiety is overwhelming, dad is mad all the time, what's going on? And so their emotional responses to that changes, and they might have more fear, more anxiety, more worry. And as mentioned before, if they need an emotional release, then they might resort to self-harm. So in a nutshell, self-harm is any intentional infliction of pain or physical damage to yourself for usually an emotional release or to calm down, and at times for attention seeking. Katie will now go into more detail about suicidal ideation, what that looks like, and how it can be identified.
Thank you, Siobhan, for explaining self-harm to us. It can be something that is hard to understand even as a mental health professional. So that's definitely a time when you want to tag in your community resources. Now we're going to go into what suicidal ideation looks like and what it is. So, myth or fact, asking a teen if they have suicidal thoughts or thoughts of killing themselves will give them ideas to hurt themselves. I'm hoping that by now in our education, we know that's false. You will never know if you don't ask. People are not going to come in and sit down and say, I think I'm going to kill myself. It's typically a thought that they hide. They know it's not socially acceptable, and especially a teenager doesn't want to alarm their parents with those thoughts, or might be ashamed themselves that they think that way because it's not consistent with their values and what they know is best for them. So the risk factors for teen suicide in particular are having a psychiatric disorder, including depression. So if you have a patient that you already know has a diagnosis, you want to make sure you're asking, which might mean changing the screeners that you use at every visit, asking a few questions before you continue with whatever reason they're there for. But if we don't ask, we won't know, which means we might need to change our practices, especially when they have these risk factors, depression being one. Loss of or conflict with close friends or family members. We've talked a lot about how overwhelming adolescence can be, the hormonal changes, the experiences that they're having, and the priority they are really placing on that peer group. So losing that peer group or having a major conflict is a red letter risk factor. History of physical or sexual abuse or exposure to violence. And our next is problems with alcohol or drugs that can impair our ability to make good decisions. And physical or medical issues. So becoming pregnant or having a sexually transmitted infection can increase our desire, or this child's desire or an adult's desire, to engage in suicidal thoughts. Being the victim of bullying and being uncertain of their sexual orientation. The LGBTQ population is at a much higher risk for suicide because of the lack of acceptance and belonging that can occur within their family or peer group, plus the actual violence that can happen against them when they do come out with their choice and they do come out with their orientation and they are now expressing that outwardly to others. That can be very problematic for them and can create a very unsafe situation. And we want everyone to feel safe with truly expressing who they are, and that can become difficult and then lead to thoughts of suicide, unfortunately. Also, the exposure to suicide of a family member or friend, it does happen that if they see a friend commit suicide, somebody in their school, somebody in their social circle, or somebody in their community, it can increase the risk that others will make that same choice. So while asking does not increase the risk, actually being exposed to suicide can increase the risk. So now we want to look at warning signs. So talking or writing about suicide. For example, making statements such as, "I'm going to kill myself," or "I won't be a problem for you much longer." Withdrawing from social contact with no other reason that you can understand. Having mood swings. Using alcohol or drugs at an increased rate. Feeling trapped or hopeless about a situation, and we're not going to know that if we're not having good communication with our adolescents. We're not going to know if they feel trapped. We're not going to know if they feel hopeless. Changing their normal routine, so including eating and sleeping patterns, that all of a sudden they're very different. That warrants a follow-up question about how they're feeling and what's going on in their internal state. Doing risky or self-destructive things, and giving away their belongings, or being severely anxious and agitated when experiencing any of these warning signs. Now, we're gonna relook at these warning signs through the current developmental lens we're working with. So are these warning signs, or are they typical developmental choices? So we have to slow down and take a moment, because some adolescents will say, "Just kill me now." And that can be very alarming, and I agree that that is not an appropriate choice of words, and we might need to create some replacement behaviors and changes, but it doesn't mean they're seriously contemplating suicide. So this is where a good screener that asks more than just one question is super helpful, and we will get there. They can withdraw from social contact for lots of reasons. They can have mood swings at this age, which we know. So all of these warning signs need to be viewed through the lens of what is typical development and when do I need to ask follow-up questions. And the answer to that is always ask the follow-up questions. If you have a teen who's presenting with some of these warning signs and you ask them if they're suicidal and they're not, they'll tell you that without hesitation. Some of them will even look at you like you're strange for asking them. And I got to the point with some of my kids where they're like, "Do you really have to ask me this? I told you no last time." And I would rather you be annoyed than me not ask, because maybe you do have those thoughts and now you know it's okay to talk to me about it because we've had this conversation before. So the screener we want to present to you, it's free. It's called the Columbia Suicide Severity Rating Scale, or the CSSRS. This is a great tool, heavily researched, and there's citations there for you as well. This is to be used in conjunction with an action plan. So you never want to start to use a screener if you don't know what you're going to do when it comes back and says that yes, this child is suicidal. So before you implement any screeners in your practice, make sure you have a partnership with a mental health provider, or your office has some sort of plan for how they would deal with the screener coming back that yes, this child is suicidal. Going through the CSSRS is also going to give us a chance to highlight the different presentations of suicidal ideation. So it tells you to directly ask, and we can make this larger so that you can see it, but also if you just go on the internet and look for the CSSRS, tons of PDFs will pop up, and the original research article as a free PDF will also pop up. So you're going to ask, do you wish to be dead? Have you thought about being dead? Have you wished that you could go to sleep and never wake up? Do you wish you weren't alive anymore? You don't have to ask every adolescent all of those questions, but you can vary your presentation based on how that adolescent is presenting to you today. We also, non-specific active suicidal thoughts is something that we don't often screen for, that I want us to spend a moment paying attention to, is have you thought about doing something to make yourself not alive? And we also want to think here of, are they doing things that are what we call in our clinical work passively suicidal? So are you not wearing your seatbelt? Are you entering a situation that you know is most likely going to be dangerous and just don't care if the outcome is that you die? So similar to the self-harm behaviors, where those atypical presentations of self-harm were extreme sports, risky sexual behaviors, excessive exercise, those sorts of things. We also want to look at asking specifically, what would happen if you died? Would people care if you were gone? Do you want your life to end? And asking those questions can be vitally important to understanding when someone's removing safety measures from their life, what is underneath that. So we also are going to ask about whether or not they have a plan. This is important between identifying somebody who might be depressed and has thought that it would just be easier to not be in this pain anymore, versus someone who is actively planning what they're going to do. So if somebody says, yes, I've thought about killing myself, yes, I want to go to sleep and not wake up, how would that happen? Have you ever thought about how you would make yourself not alive anymore? Have you ever thought about what you would do to not wake up? And again, having asked these questions to lots of children and teens, if they don't have a plan, they'll just say, no, I haven't really thought about it. And if they do have a plan, they might pause, but there's typically detail. Now, depending on their age and their cognitive development, their plan might not be possible. They might tell you that they have a plan, and you know they don't have access to the means to carry out that plan. It might even be almost fantasy-based. However, considering their developmental level, if they have thought about ending their life and they have made a plan, then we need to take action as our role as a helping professional and medical provider. So having a plan is a very important piece of this screener. So there's also some intent. So when you think about making yourself not alive, did you think this is something you might actually do? And now I love that the CSSRS gives you lots of ways you can say this, because you want to do it in a way that's natural to you. And then we look for, number 5 is active suicidal ideation with specific plan and intent. So I have said yes to suicidal ideation, I have said yes to a plan, and then I ask the follow-up question of, what is your plan? Do you know when you would carry this out? Have you thought about when you would do this? And again, if they're not suicidal, asking this question isn't going to make them suddenly create a plan. But if they are, you're giving them an opportunity to tell you just how desperately they need help. And then we rate the intensity of their ideation and the frequency. This might be the first time they've ever thought about this. They might admit to you that they think about this frequently, or the first time I thought about it was when I was in 3rd grade, but things kind of got better in my life. But now that I'm in middle school, I think that maybe I should have just ended it back then. So a good conversation is what's really going to bring some of these things to light. And it's also best to ask these questions when the parents aren't in the room. So next we're going to look for specific suicidal behaviors. So this does ask about non-suicidal self-injury, But because the two can be related, it's included in this screener. There are people who, if they tell you they're cutting and you ask them if they're suicidal, they'll say no, and they'll give you that kind of bewildered adolescent look when they're interacting with grown-ups of what are you talking about? But if you say, why did you cut yourself? And they say, well, I thought that it might be better if I just wasn't here. Then we follow up on those harming behaviors. So you just ask very specifically, were you doing this for a particular reason? Did you think it was possible that you could have died? So maybe they say they're not suicidal, but you see the cut and you say, do you think that somebody could be seriously injured or die from that kind of cut? And they'll tell you yes or no. And if the answer is yes, we want to follow up with some good mental health treatment. And so we want to know if there's intent. So not just the non-suicidal self-injurious behavior, but that intent question is important. And as you can see all along the side of this form, there's check marks where you can just check yes or no. So this is something where you can have several copies, you can have it built into your EMR. You can have this as a great way to document your conversation. And as I'll talk about in a moment, proper documentation of this conversation can help get treatment for kids who wouldn't otherwise get it. So then we want to ask about interrupted attempts. So have they actually carried through their plan but got interrupted? So this could be anything from I actually ingested pills and then I decided to throw them up, or I ingested pills, or I was about to and my mom walked in, or my plan was all ready to be carried out and my parents came home sooner than expected. It can be something like that, or they could have been in process and been saved by emergency personnel. So they call that the aborted attempt, and they can have a self-interrupted attempt. So the self-interrupted attempt is I got right to the line, I maybe even started on the steps of my plan, and I stopped myself. I had a moment of clarity, and I realized I didn't really want to die. So that's somebody who really wants help because their pain is very, very deep. So the preparatory acts, that is the things like giving your belongings away, maybe telling your younger sister, you know what, you can go ahead and have my room. You can have all my makeup that you always like playing with that typically makes me very upset. So the giving away of important belongings, or sometimes writing notes to the people that they're leaving behind. The next is we want to document whether there was lethality, because that changes how we ask families to protect people. So if the means that they chose was highly lethal, the level of supervision and protection that they need is increased. If they were choosing a less lethal method, we might have more time to intervene before something like a hospitalization is necessary. But again, you want to be a trained professional who knows how to assess before you would make that decision on your own, and you want to have excellent documentation to back up your decision, as well as notification to whoever their guardians are that this is what your decision is, and then these are the options that they have, because the family still has a choice, even if we feel like there is danger to them. Now, I'll just touch on this. There are extreme cases where a child is at risk and the guardians do not agree, where it would be appropriate to involve social services, but that's a whole conversation for another time. But just know that that option is out there if through consultation you believe that's the only way to keep a kid safe. That's not what we want to jump to. Having an involved family, having guardians on board with treatment that we feel is best, and keeping this kid safe is best for them long term. So we don't want to jump the gun. So what is a typical parent response to suicidal ideation? Well, we've got a range. We have parents who overreact and want to immediately take their kid to hospitalization. They want to change their entire friend group. They want everything to be different and everything to be okay. And can't we just fix this right now? I can't believe my kid thinks this way. We need to help them slow down. So they might believe that hospitalization is the only option for suicidal ideation, but that's just not the case. They're depending on the severity when a trained professional comes and assesses, which might in your community look differently. In Fayette County, we have individuals from the inpatient facilities who will come and do their own assessments and actually come on site and do them at a medical clinic, at a school. They'll even come to the home in some instances, and with telehealth can do those sorts of assessments over a HIPAA compliant platform such as Zoom for healthcare. They can determine whether or not hospitalization is needed. It can be traumatic for them to be separated from everybody that they love because they're having these feelings. At times, though, it might be what saves their lives. Parents may not give the adolescent a chance to talk about their experience, so this might be an instance where some of those warning signs were present, the parent got worried, but the child doesn't actually want to kill themselves, and the parent is doing all of the driving and all of the talking in the appointment. So we want to make sure we get that one-on-one time with the adolescent to know their experience, their response, and how they view these feelings that they're having and the presentation that has concerned their parents. On the other hand, we can have underreaction. We can have parents who say, "Oh, that's how they always respond when things get difficult," or they're just trying to get attention. As a mental health professional, there are lots of other ways to get attention, and so their kids are not typically going to choose a lethal method just to get their parents' attention. And no, it can be hard for a parent to accept that their kid feels this way because there can be a lot of shame and guilt on the parent's part that we need to hold their hand through. But at the end of the day, we both want what's best for this adolescent. Now, fact-based responses work best for your ambivalent or underreacting parent, which means I have this research-based tool called the CSSRS, and it tells me if they have answered yes to these certain questions, that this means they are at a high risk for completing suicide. And that's a lot harder to argue with than, well, I really think we should take them somewhere. What they're saying is concerning me. Being able to use a research-based tool and having a fact-based conversation with a parent can be extremely helpful in any situation. So how do I know when it's time to refer? So this is for any mental health condition and specifically for suicidal ideation. So knowing when to refer as a medical professional is just helpful. When you know the criteria for when you're going to tag in a cardiologist or an endocrinologist, but when do we tag in a mental health specialist? Well, first and foremost, if the adolescent requests it. Therapy is becoming way more accessible. They might have friends or other people at school who seek therapy. They might see that some kids in their school go talk to their guidance counselor and they're interested in that. So see if the adolescent requests it. Going specifically to suicidal ideation, ask them if they want help and want those thoughts to end. So if they are bought into, yes, I need treatment, it's going to be easier to have the family also on board. If you see physical symptoms that could be related to mental health concerns, we as people who are recipients of referrals would love symptom-based information. So they've lost weight consistently for the last 2 months or from the last 2 appointments where we've seen them. They're reporting loss of sleep for 2 weeks. There's no known traumatic events. I've screened for suicidal ideation using the CSSRS and did not find significant cause for concern. That is the kind of information that would be so helpful for us to build a plan for them so that we know whether we need to include crisis tools. Do we need more therapy-driven tools? Do we need a combination of therapy and medication to most beneficially treat this patient? Giving us the information that you probably already have, such as their weight, which you track all the time, is helpful for us as the recipient of a referral. If a family discloses recent life changes, divorce, moving, grief, that's coupled with negative symptoms, that's a great time to refer for mental health treatment. And if you see the same concern brought up visit after visit after visit, it's also another opportunity to say, you know what, you've told me about this more than once, and I feel like you could benefit from speaking with, insert the agency that you have a relationship with or the independent licensed mental health provider. So that means you have to make sure you're asking questions about mental health at sick visits and not just at their well child checks. So if you're asking every time you see them, doing an emotional check-in, asking if they have any thoughts of hurting themselves, asking if they have any thoughts of hurting anyone else, If that becomes a part of your routine, you're more likely to pick up somebody who is on their way to really intense or hopeless feelings instead of somebody who's already there. So, well, do I refer for medication or for therapy? Where do I send this person? Well, the easy answer is you refer for both. So the prevailing wisdom, meaning research, is that therapy first and then medication, or a combination of the two, because over and over again it has been proven that therapy and medication together bring about better results than medication alone. So families are on different ends of the spectrum with their acceptance of mental health treatment, and they might be more accepting of medication versus therapy, or they might be more accepting of therapy versus medication, but you want to make sure that they understand that research tells us that the best health outcomes come from a combination of the two. This means, as a provider, you need to get releases for any and all people you plan on referring to. It's better to have a release and not need it than try to track a family down later. So you might most likely have a longer history with this family than the provider you're sending them to. So they're going to trust you. They're going to say, you know what, she's always helped us out. He's always been somebody that I felt comfortable with in my office visits. And now you're telling them to seek this treatment. And if you can be in contact with that provider, so that provider can call you and say, hey, they've missed 3 appointments, that gives you the ability to also help and follow up and really make sure they're getting that care that they need. Well, what do we do if a family declines a referral? So, one really great ace you have up your sleeve is that families often respond differently to a medical recommendation. So if a doctor recommends something, it puts it in a whole different light. So when you speak one-on-one with your adolescent, where you typically discuss their sexual activity and exposure that you don't do in front of their parents, also use this time to discuss mental health concerns and ask them, have you wanted to see a therapist? What did your family say about that? Is this something that you would like me to recommend to your parents? And coming from you instead of from the adolescent, it will be perceived differently in most cases. So another thing to remember, adolescents can seek healthcare treatment on their own at age 16. There are additional considerations with that maybe your clinic has already thought through, maybe they haven't. So confidentiality is key for treatment success and safety. If an adolescent can't trust their provider, we're done. They might as well come and sit and stare at us for 30 to 45 minutes. Because if they don't trust us, nothing productive is going to happen. They have to trust that mental health provider, that they know what they're doing, that they have their best interests at heart, that they're on their side, and that they want positive outcomes for them. So confidentiality is key for treatment success and safety. So one thing that we always have to think through is consider who insurance summaries or that explanation of benefits is going to go to, because it lists all services you bill for. So if you are billing for mental health, if you are billing for a referral, or if they're going to an agency that needs to accept the parent's insurance, you need to consider that if they're trying to seek healthcare confidentially. We also really need to take into account what is their culture and what is their belief system. There are lots of groups that don't believe in mental health treatment. There are some religions that view mental health treatment differently than others. There are some cultures that value pulling yourself up by your bootstraps or shaking it off or ignoring that pain and plowing through and being strong, and they might see mental health treatment as weakness. So we have to work within that culture and within that belief system to help them understand. It doesn't mean that we're going to be an expert on their culture. We're not. Even if we share the same ethnicity, even if we share the same neighborhood growing up, the same socioeconomic background, the same trauma experiences, they are the expert on their culture and their belief system. So we need to let them be in the driver's seat to tell us what their culture and belief system thinks about mental health treatment, and then help them bring those two things together so that the adolescent gets the care that they need. We can't just toss that out. And at the end of the day, families have autonomy. As long as the child is not at risk of imminent self-harm, families can choose what is best for them. And they also might not feel comfortable disclosing with their primary care situation, or they might know you as their nurse outside of that clinic situation, and they might be seeking therapy that they just don't disclose to their medical provider. We've seen all ranges. One thing that I have noted in my time doing mental health treatment is that most people are scared that mental health treatment's forever. Once you start going to a therapist, you're with them for life. Well, most mental health concerns can be treated episodically, which means that you don't have to have that fear that treatment's going to be forever. Therapy and medication can be used for short periods of time and then revisited later in life if needed. It might have been a skill deficit at that time, and once they have medication that helps calm down their nervous system response and therapy comes in to teach them some coping skills, they might be able to appropriately and medically supervised wean off of those medications and try their coping skills, and they might be fine for 1 year, 6 months, 10 years without therapy. But having that initial mental health treatment being positive is a great predictor that they're going to engage with those services as needed, just like they would any other physical health treatment. So we want families to know that even by going and talking to a therapist a couple times, you're not signing up for a lifetime of sitting on a couch and taking medication. You might. That might be something that where you feel the most balanced is by having regular check-ins with your therapist and taking medication daily for decades. But we want people to know that they have choice, that they're not signing away all of their decision-making power by coming and seeing a mental health professional. They still can actively be a part of the treatment and the process, and they don't feel that way, they might need a different provider. So we have given you a lot of information, and a lot of it sounds pretty awful. So now what do we do with this? Well, I'm going to go back to self-care for a moment, and this little illustration of you can't pour from an empty cup. Take care of yourself first. That might mean therapy for you. That might mean talking to somebody about medication for you. That might mean taking care of the people who are in your household. That might look like actually taking those personal or sick days that you have every once in a while. And it doesn't have to be because you're so sick you can't move. It can be because your spirit is drained and your cup is empty and you need a day to recharge. So I will always, always, always tell you that you need to take care of yourself so that you can take care of other people, because when you're running on empty, you're not giving your best. And you deserve to feel like you're giving your best every day at work, and your patients deserve that from you too. So there's also some good things that we can talk about. There's protective factors. There's things that actually build resiliency in children and adolescents and adults that we can actually participate in. So having strong parent-child relationships. Now, we can't create a parent-child relationship, but this next one we can. Positive connection to non-parental adults. As adults, we can all provide positive experiences to children when they are in our care medically, when they're in our community, when they're in our faith group, when they're in our social circle, when they're on our sports team. We can provide a positive connection that shows adolescents that the world can be safe, that people can be different, and that I can grow up and I want to be like them. So we can provide that. That's something you can do by just being yourself. Close peer relationships, we can help to foster those. Safety at school, we can try to join committees that promote that and find ways that we can increase safety at school. Neighborhood safety, you can contribute to that in your own neighborhood by turning your lights on, getting to know your neighbors, making people know that you're a safe place if unsafe things are happening. There's an overall resilience that humans have that is incredible. As we see these great acts of the human spirit all the time, we have an ability to heal. Our brain can rewire itself. I mean, that's pretty fantastic. So there is resiliency. Having trauma doesn't mean your life is going to be traumatic. And access to health services. Well, here we go. We can make our healthcare settings as friendly and accessible as possible. That might include the way you design your waiting areas, sending out your materials in multiple languages, letting people know, hey, we're here, We want to help you, and we want to help you with any concern that you have. And then having an average IQ, so that cognitive level to be able to do metacognition, that thinking about thinking, also helps people be resilient and is a protective factor in protecting us from mental illness as well as the impact of trauma. The next thing we're going to show to you is a video, and this is actually produced by the CDC, and it's about ACEs. So we're revisiting those adverse childhood experiences, but this video is designed to give us hope, to show us that there are concrete steps that we can take that research is saying are changing the lives of kids and who eventually become the adolescents, who eventually become the adults who we interact with in our neighborhood. So we're going to take a moment and watch this video, and then we will be concluding shortly after.
Hi, this is my neighborhood. I grew up in this building. This is a great community now, but it's had its share of problems. When I was a kid, our community had high unemployment, a lack of resources for families, and lots of kids hanging out with no adult supervision. You might have heard about adverse childhood experiences, or ACEs. ACEs are traumatic events in childhood, like abuse and neglect, that can increase risk for future problems. But they don't have to. The good news is that ACEs and their consequences can be prevented. Take me, for example. I was at risk for ACEs, and despite all the things that put me at risk, some pretty incredible people helped make sure that I wouldn't become another statistic. Come on, I'll show you around. That's Jackson. He's a cool kid. His dad left when he was 2, and his mom works 2 jobs. I hang out with him every Thursday night and help him with his homework. Sometimes we grab ice cream. It's fun. Plus, he has another adult role model to learn from and trust. That's Mr. Martino. When I was a kid, he let me help him at the store sometimes after school when my parents were working late. He did that for a bunch of us. My dad actually found his job as a mechanic because of Mr. Martino. This helped our family in so many ways. Not only did my dad have a steady paycheck, which eased his stress about paying rent and buying necessities like food and clothes, but he was also a lot nicer to me, my brother, and my mom once he started working a job that made him feel good about himself. When communities come together, they can do so much to prevent ACEs. Mr. Martino and other local business owners put together a series of career workshops to help people like my dad find work. My mom also got a job with a company that allowed her to work from home and spend more time with me and my brother. Mariana has just gotten out of a class about handling challenges of single parenting. The clinic offers free childcare so Mariana's daughter, Ella, can play while Mariana's in class. The class helps parents like Mariana develop positive parenting skills, not just for babies and toddlers, but for teenagers too. This is another way our community has come together to give families the resources they need, and just one more way to prevent ACEs. This was my school, Riverside Middle, right in the heart of town. These kids are here for a sponsored summer camp. This community-supported program helps families with affordable, quality childcare and helps kids get tutoring and learn life skills. When I was a kid, I spent a lot of time at this school all year long. There was one counselor, Miss Greer, who I remember more than anyone. She was a really good listener. Miss Greer helped me and my brother get involved in after-school activities like baseball and soccer. Our coaches were super nice and were mentors to us. Staying after school for practice kept us and a lot of other kids out of trouble. When schools help take responsibility for preventing ACEs, everybody wins. My life could have gone in a completely different direction. Studies show that ACEs can have long-term negative effects on kids' health and well-being that may last into adulthood and even continue in future generations. But by people and groups taking action, ACEs can be prevented. In fact, there are 5 known strategies that help stop ACEs before they even start. You can implement them in your own community, just like we did. How? By strengthening economic support for families. By changing social norms to support parents in positive parenting. By providing quality care and education early in life. By enhancing parenting skills to promote healthy child development. And by intervening to lessen harms and prevent future risk. So, now you know my story, and you've seen the prevention strategies in my community that helped me beat the odds. I had healthy relationships with my family and friends, I learned how to take care of myself and make good choices. And today, I'm a mentor to other kids who need some extra help so they don't become an ACEs statistic. Safe, stable, and nurturing relationships and environments are essential to prevent child abuse and neglect and to assure that all kids reach their full potential. Are you thinking what I'm thinking? Banana split? You got it.
Well, thank you so much for joining us. So we figured we'd wrap up with some resources around Kentucky. You will see a list of different mental health providers located across Kentucky, and we've linked their website so you'll have their most updated provider list and where they serve. It might also be helpful for you to have a list in your facility that people can look at, maybe in the waiting area or in your office, and maybe while they're just sitting around, they can look those places up on their smartphones or on their tablets, and maybe even refer themselves. So thank you so much for joining us. We really hope that this was helpful for you in your profession, and take care.